In this video, I am demonstrating the use of the medial transconjunctival approach to the optic nerve sheath for performance of an optic nerve sheath fenestration. The procedure is done completely under the surgical operating microscope with the eyelids draped and a lid speculum placed as shown here. The first step is to create a limbal conjunctival peritomy extending from the inferonasal up to the supranasal quadrant. You can see that this is being brought right to the limbus using the blunted Westcott scissors, and that blunt dissection is used to separate the conjunctiva and tenon capsule. Radial incisions are placed at the superior and inferior aspect of the incision in order to provide maximum exposure. The next step is to isolate the medial rectus muscle. This is done with a Stevens hook followed by a Jamison hook. Both are placed posterior to the expected insertion of the medial rectus muscle, and the Jamison hook is passed entirely beneath the muscle belly. Its toe is then identified, and the muscle is gently cleaned as one would do for typical strabismus surgery. Once the muscle has been isolated and cleaned of its attachments, it is secured with a double-armed 6/0 vicryl suture. I prefer to use one with S29 needles. I place this suture with locking bites at the poles and then sharply disinserted from the globe, leaving a small stump of the muscle that will then be used in the next step. In this step, a 5/0 or 6/0 polyester suture is placed through the original muscle insertion stump to serve as a traction suture. This is an especially crucial portion of the procedure because it is proper placement of this that will allow you good control over the globe and good rotation of it into the lateral position to open up the medial compartment. I place this with several stitches through the residual muscle stump, some in a locking fashion to give good control over the globe, and once it is placed you can see that the globe can be squarely pulled into the lateral position. It's important not to rotate it superiorly or inferiorly to facilitate identification of the optic nerve. After placement of the Aruga spoon retractor to open the space and to distract the conjunctiva and tenon capsule medially, one can then follow the long posterior ciliary nerve ridge, seen here as a dark ridge on the sclera, back to the expected location of the optic nerve. Cotton-tipped applicators or similar blunt instruments are used to gently separate the perineural fat pad, which is somewhat yellowish, from the optic nerve sheath itself, which is more whitish in appearance. You can see the posterior ciliary vessels overlying the optic nerve sheath in this view. Once the optic nerve sheath is visually identified as here, I incise it with a 19 or 20 gauge MVR blade. I do this by gently picking the layers of the optic nerve sheath. Typically a gush of fluid would be seen at this point. However, you can see in this case that prolapse of fat was seen, indicating that I was not in the correct space and I was instead opening up layers of the orbital septi and fat. Now you can see that fluid is indeed welling up from an opening in the optic nerve sheath that is made with the MVR blade. I will now expand that opening in the optic nerve sheath using an arachnoid pick. You can use a number of instruments to do this if there is enough space. Arachnoid scissors may be used to actually excise a window of the optic nerve sheath. I do not think that this is crucial and think that you can get a good opening in the sheath simply with blunt dissection and without the need for removing any dura itself. Once I'm satisfied that an appropriate opening in the optic nerve sheath has been made, the traction suture is removed as you just saw, and the medial rectus muscle is reattached to its original insertion site at the muscle stump using the pre-placed 6/0 vicryl suture. The conjunctiva is then carefully reapproximated to the limbus using 8/0 vicryl sutures to allow good coverage of the muscle stump and to provide a good space into which CSF will continue to drain. Once the conjunctiva is reapproximated, I remove the drapes and speculum and dress the eye with antibiotic steroid ointment as well as a patch. I examine the patient the next day to assess for visual recovery and for ocular motility.